Good morning, everyone. Can you hear me okay? Okay. Welcome to Maui. I hope everybody's having a great time. Thank you for attending the University Learning Systems Conference. We appreciate having you here, and welcome back to all of our returnees. If you had not checked in, make sure that you check in with me when I get back to the desk, just so that I can mark down that you've been here. And then every day you will get, through your email, you will get a online form for you to fill out that will give you your credit for the day. So just make sure you fill those out. And then at the end of the conference, there'll also be a total conference evaluation that we would ask that you would please fill out. My name is Annette Bland. I am filling in for Charlene today. She is not with us this week. We've got two speakers today. We've got Dr. Christopher Bland and we've got Dr. Reamer Bushardt. Fun fact, all three of us know each other. We all went to school together. So that's just a little tidbit. It's kind of nice to be reunited together. Of course, Chris and I are married, so we see each other more often than just here. Yeah, we're so I'm actually going to go over some of the things that are in your folder just so that you make sure that you have them. Inside of your folder, you should have a list of all of our upcoming CEs. If you see anything that intrigues you and you want more information, I've got brochures in the back and you can come and get those. If you don't see a brochure that you're interested in, just let me know and we'll see about getting that sent over to you, okay? We have breakfast, so important stuff. We have breakfast in the back. Breakfast will be there till about 9 o'clock, so please feel free to get up and move around. We don't, nothing tense in here. We want you to be able to get up and walk around, ask as many questions as you want to, get as much food as you want. We'll have coffee all day as well. We also, for all of those of you that are on the live stream, please make sure that you are checking in on the live stream. And if your name is not on your screen, make sure you message that to one of the hosts so that we can get you checked in, because that's the only way we'll know that you're here. So if you choose to do live stream, just make sure when you get on that you let us know what your name is if you don't display your name. Let's see. Another thing that's in your folder is going to be the ambassadors program. This is for referring other people. When you refer somebody and they attend, then you get a reward. So if you are interested in that, make sure that you fill that out. If you like the conference and you like what you see, we would love for you to leave us a response on Facebook, and the information for that is also in your folder. Let me go through my list and see if I'm forgetting anything. Statements of credit are all going to be sent via, for pharmacists, they will only be showing up on I'm going to say it wrong. Is it the e-profile? NABP. So just make sure that you check it. We have about 60 days to correct anything. So make sure you go in and make sure that it has been correct, that you're getting credit for your CE. And if not, let us know in plenty of time so that we can get that corrected. It usually is there pretty quickly though. So if it's not there, then just let us know. If you need handouts, we've sent out the link for where you can print them. We sent the large copies, like if you wanted to download them and be able to see them on their computer and your iPad. We also sent out a link for the small 6 slides per page, which would be the better way to print them if you need to print them. We do not have printed handouts for the conference. I think that is probably everything that I have. If I've forgotten something, then I'll come back up during the break and mention it to you. Today, we are going to hear from, our program today is going to be, let's see, where is it at? Well, actually, what I'm going to do is I'm going to let them tell you what they're doing today because I can't seem to find it on here, but Dr. Bushardt is going to start and then Dr. Bland is going to finish for us today. Does anybody have any questions for me? Yes, ma'am. She will email them. They will be emailed to you at the end of each day, and then you'll fill those out. And then on the third day, you'll also get a separate evaluation for the entire conference. Okay. Any other questions? Okay.
It is fun to have a USC College of Pharmacy reunion here in Formula. How's everybody? I was kind of quiet and sleepy. So I started in Boston and came over, and boy, this morning it's like hard to beat the view when you wake up, right? I'm not sure we need any depressants if we just sort of set ourselves up here. Well, tell me where everybody's coming from. Who is from one of the islands in Hawaii? And who's coming from West Coast? Quite a few. Great. Any Midwestern folks with us? Where are you from? Missouri. Excellent. How about you guys? Colorado. Okay, beautiful. Another beautiful site. And anybody, any East Coasters with me? I grew up in South Carolina. We all did actually. Yeah, I don't sound like I'm from Boston, right? Yeah. So I've been in Boston for all of 3 months, and I haven't lived through a winter there yet. So y'all send some prayers or good vibes. Yeah, right. May have to take a sabbatical in Hawaii when that comes to be. And looking forward to being with y'all this week and the folks who are dialing in with us online. We're pretty informal, so please let me know if you have questions, if you want to stop and talk about something a little bit more, and we'll do that. And so Chris and I will be teaching you this week and working together. We can stop, we can take little breaks, we can sort of pour through things and get done a little early. We can sort of be flexible around your schedules as well. But we wanted to try to bring you sort of a taste of evidence-based medicine, some of the key issues that we see in the fields that you're practicing, and also have a chance to sort of really apply it in a practical sense. Because a lot of times we get this updates, there's 40 or 50 new drugs each year in the United States and Canada, and it can be a little bit overwhelming to figure out, what new treatments actually bring incremental value to the ones that are already here and what some of the safety concerns are. So we're going to start off with depression, if that sounds all right. And let's jump into it. So I work in Boston, and I just took a new job. If I can get this going, there we go. So I have practiced in a few places. So in South Carolina, where I trained, I worked in a cancer center, and after finishing pharmacy school, trained as a PA and have worked in family medicine and geriatrics pretty much my whole career since then. But after leaving South Carolina, I was recruited to, I was at the medical university there. Anybody been to Charleston? Beautiful, beautiful place. Maybe not quite Maui, but different pretty. But then was recruited to Wake Forest. Does that sound okay? Okay. Okay. Okay, perfect. Gotcha. Great. So then I was recruited to Wake Forest in North Carolina, where I chaired a department and worked as an executive in the health system there. And then after that, was recruited to George Washington University, where I've been for about the last 6 years in Washington, D.C. And then just took a new job at the Mass General Hospital. So if you're not familiar with Mass General, it's one of the larger hospitals in Boston, and it's part of a system called the Mass General Brigham. So there we have the Brigham and Women's, we have Mass General Hospital, and about 7 other hospitals, and it's an incredible place. They do a phenomenal amount of research and sort of all fields, including what we're going to talk about this week. And it's about 80,000 employees, so a tremendous health system, and really one that produces some of the cutting edge research. And so what I'll try to share with you today is what I've learned and studied myself, but I've also sort of harvested some of my colleagues up in Boston that are doing work on sort of the front lines of psychopharmacology. So we'll see how winter goes. I'm not super excited about it, to tell you the truth. Well, let me do the old-fashioned progression. Here we go. So we're going to look a little bit about, we're going to sort of focus on linking the brain and the drug therapies and trying to figure out how we make rational choices depending on who's in front of us and what challenges they're experiencing. So let's start with the case. I think it might help to sort of put it into context, and then we'll dig back into the details. So this is a patient that I saw 2 years ago. She was really having a hard time, and maybe you've seen someone like her or many patients like her, but she was really at a point where she had been seeking care for a few months, not really feeling better, and having a very, very hard time. A lot of things sort of working against her. So she's 56 when I saw her. She came into one of our outpatient adult primary care teaching clinics. She had been treated by the internal medicine service now for a few months, couple months, and she was sad. She was feeling down. She was crying. She was having issues with sleep. She had put on weight since the initiation of treatment. She was having enough disruption with her concentration and her focus that she had to step out of work. So she had been a secretary in a high school for a long time, sort of very loved. She loved her job, but it got to a point where she really couldn't even continue to work. She would sort of have tearful breakdowns in sort of the open area in front of the glass where the students came by. And it was a really sort of tough. She couldn't keep her concentration, very, very fatigued. So when I saw her, she was about 2 months into a short-term disability and really just seeking help. She had been treated for alcoholism about a year ago. She had had some, actually, of all the patients that I've treated over the years, she probably had the worst children that I've ever encountered in my life. They were like the prototype deviant kids. They took advantage of mom, pretty manipulative, stole from her periodically, kind of in and out of trouble with law enforcement. And she really struggled with that dynamic a lot. She had a dependent sort of outlook, and she was constantly in sort of a crisis. Yeah. She had not been diagnosed with alcoholism use disorder, but she had had a short period after sort of a issue with the son and got fairly intoxicated and had a mild like motor vehicle issue. And so she was treated as an outpatient about a year ago. She had not had a prior history of alcoholism. It was something we were sort of trying to examine, but according to her and her husband, she had not had any alcohol in the year prior to being seen. Still good to validate that, right? Still good to explore it a little bit. But she had you could pretty much track many of her issues back to family dynamics, interpersonal sort of stresses. But both of her sons at this point had moved out of the house. She had fairly good relations with one from time to time. The older son constantly stealing meds, taking things from her house, selling things of hers, really, really sort of rough. So I had met when she came into our clinic, I met her new husband. She'd been married 3 times. The first, she described the marriage breaking apart due to spousal infidelity. The second one just really couldn't get along with the kids. And the new husband was a really caring, nice guy. He was overwhelmed, as you can imagine, because he had not seen sort of Geneva in this state. He didn't really know what to do. He was sort of overwhelmed by the symptoms of depression and anxiety she was feeling. But he was there, he was supportive, and he was trying to figure out how we get her better, how she gets better. So at that point, she had a little bit of debt, but nothing to be concerned about. The alcohol use that I mentioned. In sort of our second visit, she reported some inappropriate sexual contact with a male relative as a teenager. So that was definitely an issue we wanted to pursue a little bit more. Tremendously guilty. And I would say if to sum up my overall impression, she was like a worrier, a pathologic worrier. She worried even about how much she worried. She was really, it was a invasive type of expression of anxiety for her. And very, very concerned that her marriage was going to fall apart, that she was a horrible wife and terrible mother and all those kinds of things that sort of were pervasive. So she had taken the leave for job and she had been treated now in the internal medicine clinic for about 3 months. This is what she was being treated with when we saw her. So she was being treated with mirtazapine, hadn't really reported a significant improvement in mood. She wasn't like mood charting or anything, but just subjectively, she wasn't feeling less depressed. She had had about an 8-pound weight gain since the initiation of that treatment. And when the sort of lead resident in the clinic took care of her the last visit, she expressed some suicidal ideations. That was when she sort of said, I can't handle this anymore. And so he referred her in. And we had sort of a neat program there where every Wednesday, one of the attending psychiatrists would come into the adult primary care clinic and he would run sort of a co-managed clinic. So one of us from the internal medicine side and the psychiatrist would see sort of internal referral. So anybody that needed more intensive mental health psychiatric support. So Dr. Scholar was there with us and we saw her on one of those Wednesday afternoons with the benefit of having a primary care team as well as the psychiatrist in place. So that's kind of where we are. So before you even go forward, what are you thinking? What would be some of the things you might want to pursue or evaluate or explore with her? Yeah. Why did they go for mirtazapine? That's a really good question. Sometimes residents do really interesting things. I'm not really sure. It definitely wouldn't have been a first line choice for me, but if she was, my gut says she was having trouble sleeping. And so maybe they thought, let's do some mirtazapine at a lower dose in the evening and, you know, see if we get a little better. But there was in the 2000s, there was a large study by the Veterans Administration that actually showed if you improve sleep in individuals with depression and do nothing else, you just improve sleep, about 80% of them are clinically significantly improved. So if it had helped with insomnia, maybe it'd have been a good choice. But it's sort of a little side effect rich, so it wouldn't have been my first go. But sometimes people make bizarre prescribing choices. Other questions. What would you be pursuing? What would you be evaluating or thinking about for her? What do you want to know about her that we haven't shared? Yep. So the side effect, potentially the side effect, the increased appetite she had could have been part of her depression, right? But it could also be maybe related to her treatment. So I think again, if like you say, when people are depressed, there can be hypersensitive to somatic issues, and this was definitely at the forefront of her concern. She was concerned about that. It definitely wasn't helping, and it's probably long enough at this point, 3 months in, with daily therapy that she and her husband endorse she's using. If we were going to see some benefits, we would probably have seen it by then. Yeah. She really had I'm gonna just repeat your question for the folks online. There weren't really any other comorbidities. I'll share you a little bit about our past medical history, but nothing in the space of just the substance use concern, but no history of depression, anxiety disorder. So as a child, she had meningitis and an arm fracture. She had a strong family history of depression, but she herself did not. And so she had some cardiovascular issues on mom and dad, but two sisters, one committed suicide in college and another was doing really well. And the older sister, was like a banker, had a very successful career, good, strong family, and had been doing sort of pretty well, but both had been treated for depression and anxiety. She had a high school grad, and as I mentioned, was a school secretary. Um, and she used a good bit, 4 cups of coffee a day. That's a little on the higher side, but not out of that. Maybe also be like one venti or whatever that size is at Starbucks that looks like a IV bag, and a little bit of marijuana in high school, but no, not any illicit drugs since. So not a lot, but I'm going to teach you some things about how to potentially pick an antidepressant or antidepressant regimen as we evaluate a patient based on their symptoms. But let me just say that if her older sister is doing well, or any first degree relative is being treated for the condition doing well, forget everything I say and try to replicate whatever sister is on. Because if you have a sister or a brother or a child or a parent who's responding well to a psychotropic drug like an antidepressant, phenotypically, she would be very likely to respond well. So we could just stop here, get on the phone with older sister and say, "Hey, can you tell me can we tell you what you're taking if you're doing well?" And we could try to replicate it. But we didn't have that opportunity when we were together. So we did eventually find out what sister was taking. But definitely the phenotyping, you can look for first degree relative responses. So these are the meds she was on. She was on the mirtazapine. It was started at 15 milligrams, was increased to 30. She'd been on 30 for 2 months. It was a contraceptive that had been used for some type of short-term abnormal bleeding situation, kind of months before. A neighbor had suggested that she use St. John's wort. So in about 2 weeks before I saw her, she had started using a 3 times a day St. John's wort Hypericum supplement. She was using a good bit of Tylenol. She had headaches, her body ached. She had quite a lot of pain complaints. And she had used over-the-counter sort of allergy and cold medications, but not in the recent months. So this is really everything that we know about. And again, she and both her husband endorsed no alcohol in the home, no alcohol within the last year. So what are you thinking here, medicine-wise? Let me just ask you a little question. We already talked about mirtazapine a little, but what do you think is right here? What's most accurate? Do you think mirtazapine is an activating antidepressant that can aggravate her insomnia? Who are my A people? None. It's relatively weight neutral B with regards to effect on sleep or weight? No, not even any onliners. All right. Associated with drowsiness and weight gain? Yeah, I think so. Absolutely. Or it's been shown effective as a mood stabilizer. No, it's weight gain. Because what is mirtazapine? It's basically antihistamine when you start it. So you get kind of like you're given cyproheptadine to help somebody boost their appetite. You can create anticholinergic effects. You can create increased appetite. You can create sleepiness, not the restorative kind of sleep. But you can make people drowsy. You can make them dizzy. And then as you move it into higher doses, like 30 milligrams and beyond, you get a more traditional SSRI-like sort of effect. In geriatrics, we use mirtazapine all the time at about 7.5 milligrams as a way to stimulate appetite and be quite effective. But I rarely would start mirtazapine as a first-line antidepressant. It's got too many side effects in my experience for that. So what would you be thinking about next before we go into the antidepressants? Do you think, I mean, I feel pretty good that the diagnosis is right because we've had a psychiatrist here use structured interviews and he's verified, that this is a major depression first episode. He's talked with her husband. We've also done percent CD4 testing to make sure that there's no evidence of alcohol use, which there's not. So we're not thinking this is a substance use mood disorder. We're feeling pretty good about our diagnosis of major depression. But what would you be thinking about next in terms of the mirtazapine she's on versus what we might want to do? This is her first antidepressant. Trip to Maui, it'd do it for me, let me tell you. Not very. She's pretty sedentary. Yeah, so thinking some non-drug activities. Get some vitamin D, truly, maybe not at Maui, but get some sunshine, get some physical activity, get some endorphins going. I think that would be something she and her husband could do together. What else? What else would you want to know to try to narrow down maybe on a different type of therapeutic intervention? I mean, her depression is significant enough that she's not able to do a job she's successfully done for a long time. So she's definitely having negative effects in her ability to work and participate in society. And she's there asking for help, sincerely asking for help. Well, let's talk about the drugs a little bit and then see if we sort of can narrow in on some thoughts. And I'll give you some models I've used to try to figure out how to choose an antidepressant. At some point, we're going to be able to do a lab test probably and determine the 2 or 3 antidepressants that somebody's most likely to respond to. But we aren't there yet in daily practice, although they're doing some versions of that in research labs around the country. But right now, the best we could probably do is do some blood tests to tell which antidepressants might be hard for the body to eliminate, but we don't really have any yet that we can use to say one of these 2 drugs is likely to get you a positive response in 3 or 4 weeks. We're not quite there yet, so we have to sort of wing it a little bit till then. But this is I had a pharmacy colleague in Winston-Salem who created this little sliding board, but I find it very helpful because one of the things that you can do in depression is you put all the antidepressants in a bag and shake them up. They're fairly equivocal in their response. About 30 or 40% will respond, sometimes as many as 50 if you combine psychotherapy with it. But by and large, there's not like one magically superior antidepressant that sort of outshines all the rest. There's a lot of inner variability, but the drugs themselves are generally equivocal in their overall efficacy. So sometimes what you can do is you can either avoid side effects that will make something that the patient's experiencing worse, or you can try to take advantage of a side effect, a common effect, adverse effect of the drug to create some value. So like, for example, with the mirtazapine, maybe they're thinking many people are drowsy. So why don't we use a bedtime dose and see if we can improve some of her insomnia, and maybe that will help her feel more energized in the morning, kind of have her hands a little bit more free to do the work to get past the depression or get through the depression. But in some cases, if she's coming in saying, my appetite is up, I'm having insomnia, we just want to make sure we're not choosing a drug that's going to aggravate that existing complaint or something else, because they're going to feel it, they're going to get discouraged, and they may stop treatment altogether. So this looking at the activating versus sedation, these are going to be your more activating antidepressants, sort of get out of bed sort of antidepressants. You can see a few here: bupropion, sort of in a class all its own. We don't even exactly know how bupropion works. We think it has something to do with dopamine and norepinephrine, but they've never really been able to determine it. It just anecdotally found that it helped with depression, so we use it. But it seems to be therapeutically distinct from the other ones. We have venlafaxine and desvenlafaxine that are going to be mixed action agents, have a little serotonin effects, but also some noradrenergic effects. And then you have, again, some mixed action drugs. So these are going to be the more activating ones. So she's having insomnia. I would probably not first go to bupropion for her because it's probably going to aggravate her insomnia. She also has a history of alcohol use. So I'm not going to want to use bupropion because bupropion and alcohol aren't good friends together when you mix them. In terms of the most sedating, mirtazapine tops the list, and then the tricyclic antidepressants and also the quadricyclic trazodone. So remember when tricyclics were first out, they worked pretty well, but they were potentially fatal or sometimes fatal in an overdose, had lots of toxicities, and so they created a fourth ring and made trazodone, which made it a really good sedative and a really crappy antidepressant. So there's nothing really here that I think is easy to go to for us, except for the mirtazapine. But that's going to be one of the more sedating. And then kind of in the middle, somewhere along the spectrum, is fluoxetine. It's relatively neutral, but a bit more get out of bed. It's on the activating side of the spectrum, whereas paroxetine is the most sedating of the SSRIs. It's also more likely to cause a little weight gain. And then the ones that are most neutral, that sit right in the middle in terms of activation, are going to be your sertraline, Zoloft, prescribed all the time in the United States, and then citalopram and escitalopram. So you can think a little bit from just this perspective about maybe where would you be thinking to go next if you wanted to stick with an SSRI or a mixed action agent, but you wanted to try to avoid worsening her effects. Some people kind of have that pull the cover over your head depression where they don't want to get out of bed, and using an activating agent can be really helpful. Whereas if she's constantly worrying, have a lot of anxiety overlay, and have an insomnia, an activating agent may actually make things worse for us. Sort of make a little sense? Little quick fact while we're here. I'm not a big fan of like the Me Too drugs where designer pharmaceutical companies make one tiny little tweak and then charge another $300 a month for the medications. So, but citalopram, if you spin off the left-sided part of that molecule, they made escitalopram or Lexapro. This is one of the examples where they actually did make a better product in my experience because it's generic now, so it's an inexpensive product. But in the UK, they have seen issues with some cardiovascular risk associated with higher doses of citalopram or Celexa. So 40 milligrams and above has been associated with harm, whereas if you look at escitalopram, which gives you really equivalent efficacy, but we haven't seen any of the safety concerns. So this is a drug, unless you're going to use it at lower doses, it's probably worth thinking about maybe shifting to escitalopram as opposed to citalopram if you're starting somebody new. Questions about that? Yes. Mm-hmm. No, I mean, the only thing is if they are able to eliminate the drug regularly, you should be able to use 20 milligrams or less and be okay. 40 milligrams would be a risk because of the harm studies. But if a person has a problem like acetylating that drug and clearing it, which they can occasionally do, then you might have a higher perceived dose than that you're actually given if it's an older patient. So, I mean, what I tried to keep, I like to live by the KISS principle, the keep it simple, stupid thing. And so anything I can do from a drug therapy point of view to make my life a little simpler, to make the patient's life simpler, I do. So when I reviewed those trials and saw the citalopram and you put these head to head and there's literally no difference in the efficacy, I just eliminated this drug from my life because it's cheap to use escitalopram. It's easier to deal with. You don't have to worry about a dose. So I think if you want to continue to use citalopram, just keep the doses at 20 milligrams or less. If you want to think about using escitalopram as an alternative to citalopram, I think you would see the same effects and you wouldn't have to worry about cardiovascular risk. Nobody's going to sign up for the study where they take the high dose for 5 years to see how many of them have heart attacks. So we only are going to have associative research, but it's enough for me to worry a little bit about it. Did I address your question? Okay, awesome. Sure. Yeah. For prestige. Yeah, I mean, it depends. If we're talking about older adults, they tend to have more of the CNS effects. Really either. So in a younger patient, you're going to see a little bit more weight gain and increased appetite with paroxetine. Still, though, the number one side effect with anything that's working on serotonin, whether it's a mixed action drug like Prestige or SSRI, is going to be stomach stuff. And if you can have them hang in there with you a little bit, because the serotonin beds in the stomach and the intestines are getting kind of used to the drug, they may have loss of appetite, they may have diarrhea, they may have increased appetite, they may have nausea. If they can kind of hang in there for a few weeks, they'll generally settle down. So it's the GI stuff up front always, but in older populations, I see more drowsiness, dizziness, confusion with the mixed action drugs like Prestige and paroxetine. I've used that drug for many years, and it's notoriously tricky on weight gain. It's probably the number one reason I discontinue it long term, but it's a good one. It's just you're solving one problem and then you're creating a new one. So I really have sort of my own practice. I have really prescribed these right down the middle 80% of the time, because between sertraline and escitalopram, it pretty much works well in the majority of people I see, and then I'm not having to worry about the sort of the symptoms on either side. And they're both generic and cheap. So, and here's sort of your sort of full spectrum. But so if you think about the patient, Geneva, we're talking about, she's got major depression, she's got some melancholy features. She is expressing suicidal ideation, but she is seeking help. She's doing the right thing. She's in a supportive relationship with her husband. So now the question is, what are we going to do in terms of her treatment? We're definitely going to look at her diet. We're going to incorporate exercise. We're going to incorporate some vitamin D, get her outside in some sunshine. But what do you want to do in terms of drug therapy if our goal is to try to reduce her symptoms, get her back to work, maybe work on this marriage that she's in so she can continue to have a successful relationship? We definitely want to think about this point whether we're going to treat her for a short period of time, or maybe is this a lifetime commitment to antidepressants, and how do we get her on a drug therapy regimen that she can live with, that she can work with, and that she'll stick with. So where do you want to go? What do you want to do next? You tell me. Let's talk about it, and let's talk about the pros and cons together. She's your patient. She's coming to see you. She's in your pharmacy. She's in your clinic. Where do you want to go next? But I can tell you, if you keep her on mirtazapine and she gains any more weight, she's done with us. So you want to stop the mirtazapine and go to another sort of serotonin-based drug like an SSRI. They're definitely the first-line therapies, and you're thinking about sertraline. So it'd be right down in the middle. We wouldn't really expect to see much in terms of sedation or with activation. Pretty easy to titrate the dose up. Okay, so we got to vote for sertraline. We don't yet know what older sister is on, so that's in the back of our mind. What else? What other options do you want? Mm-hmm. So, so one option is, so she's on a short-term disability. So she's like if someone was going out on a surgery. So she's on a short term with the expectation that she's going to come back. So that's good. But your point is if someone is having that significant of an impact of the disease, maybe having a specialist to refer into psychiatry or psychology would be a thought. I think that's another rational sort of thing to think about. I mean, that's what's happened here, right? The internal medicine services says we've tried for 3 months to treat her. We've, provided the sort of typical care we provide in primary care, and now they've sent her to the Wednesday clinic with psychiatrists. So that's consistent with what happened here. And it doesn't mean that the psychiatrist can verify the diagnosis. They might make some changes in the drug therapy regimen, and she could be transferred back to primary care for the maintenance of that regimen. Or if it's more complicated, the psychiatrist might keep her and manage her for those issues. So I think it's a good alternative. What other ideas do you have? I mean, these are some of the drugs. Anybody voting for tricyclics? No. I mean, the weird thing is if you have major depression with melancholy features. Tricyclics are notoriously quite good for that, particularly in white women for some bizarre reason. But because of her suicidality and the likelihood of adverse effects and toxicity, there's no way I would prescribe a tricyclic for her. I think an SSRI is a reasonable option. Give another one a try. I'm in my mind also thinking I've had her, or the team has had her, on basically a serotonin-based therapy with the mirtazapine now for 3 months, and she's not showing any response. So does it behoove me to maybe try something different? Would the sertraline be effective, or would be 2 months in and we're basically having maybe less weight gain, but the same minimal effect on her depression symptom? I don't know. There's no magic to know. The quickest SSRI in terms of showing a therapeutic response is escitalopram. You can begin to see therapeutic effects with it in about 2.5, 3 weeks, whereas most of the other antidepressants take about a month or more. Yeah, so we had in terms of physical pain and sort of menopause questions, I was also a little concerned whether or not some of this might be related to menopause. So she saw one of our gynecologists, and because I was also a little miffed and there wasn't good records on why she had been on that short dose oral contraceptive, but it didn't turn out that hormone therapy or other options were recommended for her. So, but it's a good point. It's a good thought. Because sometimes during that sort of perimenopausal period, we can see pretty disruptive anxiety symptoms, depressive symptoms, sleep issues. So I think a really good thought, but it wasn't the answer for her. I mean, when you see her, there's a tremendous amount of noise in her psychosocial and personal life. And then she also had this trauma history, which I think has probably plagued her and made it very difficult for her to have successful relationships for a long time. So she has a strong impact of prior history and trauma now with really difficulty just navigating life, and anything that escalates the stress of a situation, she really begins to shut down. So she's got, I mean, in my mind, it's going to be hard for primary care alone to take care of her. Her husband probably needs support. She needs support. The relationship with her sons and her definitely needs some professional intervention and so forth. Yeah. Yep. Uh-huh. You're tired. Yeah. So to kind of summarize, and for our folks online, so it can become sort of a vicious cycle, right? If we're not active, if we're not burning calories, and then it's good to come home from work or after exercise and be tired and sleep, right? I mean, that's sort of a healthy. And so for her, she may be in this sort of vicious cycle where she's just worrying and half sleeping, drowsing day long. I think it's a really important point, and that's another reason why physical activity in a routine, whether it's a work routine or a social routine, is very, very helpful. She might not be motivated to get up and out, but maybe she and her husband could walk together or do other things, leave the sons out of for a little bit. But your idea about a mixed action agent is a good one because we've tried her on a serotonin-based product. So I think it's possible we could try another SSRI. But if you wanted to go in a different direction, because we've had sort of a failure of the mirtazapine, I think using a mixed action agent like venlafaxine or duloxetine would make good sense. Because she is having pain complaints, and maybe some of the noradrenergic effect, like you see with duloxetine or even venlafaxine, could help relieve some of those somatic complaints. So kind of what you're thinking is she's having a side effect of her depression, the it hurts everywhere effect, and maybe this would actually benefit that a little bit. Plus, it would give you a different way to be. The nice thing about duloxetine is that you get mixed action right off the bat. You don't have to titrate it up. So like with venlafaxine or Effexor, when you start low, it's basically an SSRI, and you push the dose up, and when you get sort of higher into the 100 milligrams and beyond, you get more of a noradrenergic effect. That's why we kind of watch for the blood pressure and heart rate kind of thing at higher doses. But duloxetine, you get mixed action right out of the get-go. So either one of these would be okay. A little bit of safety concerns about liver health and duloxetine. So we just want to make sure she doesn't have any
issues with LFTs or liver injury, which not suspicious of that, but that would be worth the thought. So some good thoughts. And then again, if we find out what older sister's on, forget everything I said and do that. You with me? I mean, there are other therapies as well. I don't think for her out of the get-go, but for refractory disease, we have certainly ECT, which has a tremendous body of literature. But what we're seeing more and more, at least in our center, I have a TMS lab on the campus where I work, is transcranial magnetic stimulation therapy. Repetitive use of TMS therapy has shown good results in depression and some evidence in bipolar disorder. And so that's another modality that can be used as an adjunctive therapy as well, and gives you pretty quick response. So I'm going to kind of go through and we'll revisit what ultimately happened with Geneva, but I wanted you to think a little bit through and then let me share a little bit about how I make decisions and see if that changes the way we think about it. Are y'all with me though that we would want to use a combination of some type of psychotherapeutic intervention, lifestyle changes, as well as a drug therapy? Are we all, anybody not on that page? And don't be shy if you aren't. Okay. We're going to maximize the likelihood she's going to be successful if we have a social worker or psychologist or a counselor, somebody working with her. Probably cognitive behavioral therapy, but I would say family therapy would be a reasonable thing. She could even try some biofeedback for the anxiety, but I would get a professional to help her learn to cope and address. And a good psychologist friend of mine that helped train me as a pharmacy student, always said when you're depressed, your hands are so full of the depression, you don't have the ability to do the work it takes to address the things to help you gain more control over your mood. And so if we can relieve some of that symptom burden, then she'll have the hands free to do the work with the therapist to make sort of hopefully sustaining changes in her life. And I think that's sort of a good life lesson. We used to have to go in the room with the patient with a little bug in the ear. And as soon as we get off the track, the psychologist would say, no, don't do that. And she would guide you back. It was a really great way to learn as a trainee. Definitely want to stop St. John's wort, right? I mean, there may be people that could use an alternative therapy, but she's having disruptive major depression, so we're not going to use St. John's wort for her. All right. So one of the things to think about, and then I'm going to sort of go through the drugs, is if we want to change her, sometimes the transitions in psychiatry can be a little tricky. So like, for example, we mentioned over here, we wanted to stop the mirtazapine and start sertraline. So fluoxetine is the tricky one because it hangs out for a long while. But this is a good little guide I've used for a number of years that helps you sort of follow that if you're stopping one antidepressant, want to go to another one, what is the expert advice on how to do that? And the one that just is a little bit trickier is fluoxetine because it's good to have sort of a washout period. And if they're older, you can even give it a little longer washout period. This is just some stepwise tricks to help you switch from one agent to another. Sometimes it's okay to keep them both going. Sometimes you just really need to discontinue one. What I sort of think about with antidepressants is they usually have a low dose, a middle dose, and a high dose. I very rarely prescribe the high doses. I'll usually use more than one drug at a medium or low dose combination. But if I've got someone on a medium dose, I may pull it down to a low dose for a short period of time before I start the other one. But this guide is pretty golden rule. It'll get you there. All right. So in terms of the DSM, she was diagnosed with major depression. She had melancholy features, and then the other sort of thing in my mind is what's going on with her. Why do people have depression? What is in the brain going on biologically or physiologically that's creating depressive symptoms? What did you learn? What's your working understanding of that? What's going on there? Well, let's do a little exercise together. So how many people have had any kind of fast food through a drive-in window in the last 20 years? No? 30 years? All right, you don't have to admit it. I'm not going to judge you. You're not on camera, but let's say that you have. All right, you pull up to the drive-through and you order a combo meal number one. We're going to keep the drink only at 36 ounces because we're being healthy today. But you got your burger and you have your fries and you have your sugar juice, right? Sugar water, Coke or whatever. And you're getting ready you pay for it and you're getting ready to pull out, head home. Maybe you've been at work all day. What do you probably all do within the next 90 seconds. Inhale it. That's sort of an outcome. Let's go a little further. What would be the first action you might take as you drive away? Put the straw in the drink. Okay, that's different. You're in the minority there. Eat a fry. Like, how many people eat a French fry? Actually, clinical studies, not clinical, but we've done sociologic studies, and actually 98% of people eat a fry within the first 90 seconds. And why do you do that? Because they're amazing. Well, yeah, well, I mean, but deconstruct it a little bit we're going to understand depression at the end of it. So why do you eat the fry? Okay, so it's easy to grab. Your brain is telling you that I can probably collect this food without causing a motor vehicle accident. So you made that rational decision to choose an excess. Okay, what else? It's many layers. Okay, so let's deconstruct that. You've had one before, so you know what it's like. And so the dopamine in your brain starts to go, and you are anticipating the deliciousness of anything stuck in liquefied hot oil for a little while and then heavily salted, right? So you've got that dopamine reward, but you've also benefited from the salt and the fat, and all of those things are layering on reward. And so you're got to have it right now. It's part of what your brain has learned to do. You didn't come out of the womb wanting a French fry, right? Or knowing the pleasure that it produces. That's a brain neuro adaptation that you've had from having one before. What else? So there's some rational thought about this is a good choice to make of my options, right? What else? So maybe the traffic was really heavy, or somebody called you and you got home and you had to have a cold fry. How was that experience? So your negative reward process is saying the longer I wait to have this fry, the less pleasurable it'll be. And so they're all of the point of it is your brain has neuro adapted to this life experience you've had, which is the drive-through experience. And the circuitry in your brain, the salt center, the reward center, and the caudate nuclei, all of these places have coordinated a reaction and probably physically changed, neuroadapted, to create this behavior that we have when we go through the drive-through, which is as quickly as possible, grab that French fry. So if you think about it, you have multiple areas of the brain working together in a concerted neuro, we call it a circuit, but it's a set of pathways that have formed, and that behavior that you feel, that expression of the need to have that fry, is a part of those conscious and subconscious processes. So if you think about a person with depression, they may have had trauma, people may have had a brain injury, or you think about Parkinson's disease, or you think about schizophrenia. We have various, or maybe adverse drug abuse, illicit drug use that's caused physical damage to the brain. The circuitry that exists to drive our normal behaviors becomes negatively impacted or diseased or harmed, and it changes our behavior. So in a patient with major depression, the hypersomnia or the loss of pleasure or the whatever behaviors are part of this abnormal circuitry that has manifested. And we used to think, like when I was Chris and I were in pharmacy school, I mean, I look younger than him, but we were in the same class. No, kidding. When I was there, they were telling us that this was like deficiencies of neurohormones. Like we didn't have enough serotonin. And so Lilly came out with Prozac and you gave that, and then you had more serotonin, and it was like almost like hormone replacement therapy for the brain. But that's not true, because in about 48 hours, the neurotransmitter levels are up after you give a patient an SSRI, but we don't have people that are therapeutically better in 48 hours. And then after a little while later, they thought, well, these little channels that the neurochemicals use to communicate its effects kind of downregulate. They get kind of skimpy. And so it takes a couple weeks to synthesize new proteins. And when you give an SSRI, you start to see more gates open up, and there's more ability for them to exchange of those chemicals. But then we don't really see people with drug therapy improve them within 2 weeks. And now, sort of fast forward ahead and functional MRI studies and kind of better understanding of brain neurochemistry, we understand that it's actually circuit dysfunction, and that over the course of 3 or 4 weeks, It happens much more quickly with ECT or TMS therapy, but with drugs, when you increase the synaptic level of neurotransmitter by creating more, by blocking its uptake or whatever the mechanism, then you begin to see that effect begin to sometimes often overcome dysfunctional circuitry in the brain. Some can't be overcome. Like I have patients that have brain injury or that have had harm to their brain because of illicit drug use or a stroke, and you can't. I mean, you can try to help them neuroadapt in other ways, but you can't restore that part of the brain that's been physically harmed. But the vast majority of people we see are having a circuit dysfunction that's not related to physical damage to the brain. And you can overcome that with the therapies that increase those synaptic levels, and they chart new pathways. And we can also help them neuroadapt by having psychotherapists work with them to help them come up with better ways to respond to trauma and things like that. Begin to make a little bit of sense? So don't feel bad when you have your drive-through experience. Just don't do it very often, but your behavior is programmed. And I do love a hot French fry. They're delicious. Yeah. hmm hmm Well, the pattern of depression is not like, getting COVID, where the virus comes in and sets up this cascade. That's probably terrible because it causes all kind of weird things. Like the flu. We'll do the flu since it's on the rise in South Carolina this week. It's not. The people that we're seeing with anxiety disorders, with depression disorders, there's a combination of physiologic or pathophysiologic disease processes with all of the adaptations and environmental effects that they've experienced. So we're seeing a complicated cascade with a lot of things going on. And so I think that's why we layer on the different treatment. We can put in the drugs to try to improve circuit function to decrease negative or adverse symptoms. But if there are things that have been going on for a while, unless it's like a situational depression, the brain is probably physically changed and we've responded and adapted to it in ways that may be helpful and it may actually be making things worse. And so it's not an easy road, but there are proven strategies to help people overcome the disruptive symptoms of depression. So I'm with you on that. Okay. So, just to kind of go through the list again, and then we'll take a little brain break. Y'all been working really hard for me. So I appreciate that. Is that for her, monotherapy for her first case would be a reasonable thing. You could leave the mirtazapine and add another agent onto it and modify her. Let's say, like, I don't want to do that because she's having an adverse effect, like with weight gain. But let's say you started her on sertraline, like was mentioned here, and she's having some improvement, but not a lot of improvement, maybe modest improvement. And let's say we're on 100 milligrams of sertraline, Zoloft at this point. Maybe you're seeing some benefit, so you don't want to stop it. So you want to add a second drug onto that antidepressant and modulate it. That would be a strategy. Or you could say, I'm not seeing the benefit I want to try another antidepressant agent. So I'm looking for, are there any measurable improvements? And you can use symptom surveys, but what I usually try to do with patients to keep it easier is I have a mood chart. Just write a little bit in the notebook, how you're feeling each day, and then we'll sort of look at it. Because sometimes people come in and either they magically feel better or they're trying to make you feel like they feel better, or either they're having a really crappy day and then it sort of alters what we do therapeutically. So looking at a little mood chart, some people, there's even some mood charts they can just check a little box. It kind of helps you see what the pattern is over the period of time since you've seen them last. Or you can do like MDQs or structured surveys if you want and look for scores from here or there. But I think, using an augmented therapy or just changing to a monotherapy would be okay in either way. I'm always, in a person that has as much noise in her life, going to use combined psychotherapy with the drug because she's got life issues that are going to be constant triggers and she has really trouble dealing with stress. I'm not going to use one of these agents. If someone had really issues tolerating the antidepressant or had tried 2 or 3 and failed, then I would work with psychiatry to explore whether TMS therapy. And I don't know if you've seen it, but it really is miraculous. It's like going into a dentist's office. You sit in a little chair, They direct the transcranial therapy. It doesn't cause a seizure. There's no amnesia like you see with ECT. You don't need anesthesia. And they go in for these very quick in and out, sit in the chair, have it. And, in a matter of weeks, I've seen really dramatic results. So if you aren't familiar with TMS, you might check out and see what your closest treatment center in your area is and just sort of maybe read about it a little bit. So it's a sort of revolutionary therapy for a group of patients that don't respond well to drugs or that don't want medication therapy. There's a lot of guidance from different groups, and so I just shared that with you here in your slides. These are guidelines. I don't really find that cookie cutter approaches reliably get me good results. So I try to look at individuals and think about, number one, are there symptoms there that I know drugs can help? If someone's having fatigue or panic symptoms or delusions, or someone's having sleep or appetite disturbances, or someone's having this kind of depression fog that Geneva was having, I know that medications will help with that, and it reliably translates in the clinical trial. So these are symptoms that the antidepressants are really good at helping. Withdrawing symptoms, those kinds of like feelings of isolation, withdrawal, guilt, not so good. That's going to require a different approach. The medications that will help with these target symptoms pretty reliably. And then the other thing I'm also thinking about for her is as I initiate an antidepressant, I may be increasing her energy and vigor. And if she is suicidal, I can put her at greater risk for suicidality. So one thing I want to make sure as I initiate it that I'm checking in with her early on as the drug therapy is going, and that I've contracted for safety with her. She's got someone living in the home with her. I don't want to make sure she's not by herself for long periods of time. And also talking with the patient to say, if you're feeling like you're overwhelmed and you can't do this anymore, you're feeling about causing harm to yourself, you have to agree with me that you're going to do this. And it could be a number or someone you're going to call, and we'll put that plan in place. And I prepare them to say, you may feel more activated, you may feel more nervous energy, and that's part of the process, but I just need you to let us know if you're feeling unsafe, because we can help you at that point. So I'll put that in place for her. But, in terms of the way I think about depression, I just sort of talk you through it here in the last couple minutes. What's also present in your slides is I've gone through all of the drugs and I've listed all their dosing schedules and toxicities. I've put in drug interactions, and I've also put a handful of little resources about how do you deal with sexual dysfunction with an antidepressant, or how do you deal with switching from one to another, or when does combination therapy make sense and not. But my go-to approach for someone like Geneva would be to think about what syndrome or what collection of symptoms she's presenting with. And a geriatric psychiatrist taught me this a long time ago, and I have used it for 15, 20 years. It's not based on brain scans. It's based on the clinical experience of psychiatrists like him. But he always said you can look at individuals and often put a pattern around it, and you can determine which neurotransmitter is probably significantly involved with their depression symptom. And so a person with a serotonin type picture would be they'd be sad, probably tearful or crying, or definitely feeling decreased mood. But there is often an overlay of anxiety with it, or there are issues with food or appetite. It may be up, it may be down, but there are issues with food and there are issues with anxiety that overlay the depressive symptoms. And if that pattern is very predominant, then you're pretty assured that serotonin is involved. And that actually pattern exists in the majority of patients we see in primary care with depressive symptoms. For people that have more predominant noradrenergic effects, you tend to see a little different view of symptoms. You often see the loss of concentration or focus. And I'm not saying that everybody with depression might not feel a little fuzzy, but to the point where you can't do the job you've been doing for a long, long time. It's a predominant disruptive symptom. Fatigue is often highly present in the patient with high noradrenergic, really feel physically unplugged. They just can't go. And pain complaints tend to coexist in noradrenergic. They're going to have more headaches, more body aches, more things aching and hurting. And then on the dopaminergic side, sort of the last syndrome that's been described, it's more what I would say the person that tries to sleep through their depression by putting the covers over their head. They're hypersomnic. You usually see a real predominance of anhedonia or loss of pleasure or interest. And you may also see that form of pseudo dementia that can happen in some patients with depression, where they almost feel like they have dementia, but you treat the depression and those symptoms go away. That sort of cognitive sort of slowing. And I can compare those a little differently, because in the person with neurogenergic dysfunction, I feel like I'm having to push the conversation. Their speech is hypokinetic, their movements are slow, and I feel like as a clinician, I'm having to work harder in this interview to move things along. That's a different feeling than the serotonin picture, where there's this overlay of anxiety or worry, and it can sometimes you can feel it in your chest sometimes, because that energy sort of projects on you. You can sort of begin to get a sense. You have to not overdo that model, but you have to look and say, if I'm going to narrow down what the most predominant effect would be. And if I think about Geneva, she doesn't give me a pattern of a dopaminergic. She's not in a state of anhedonia. She's not having dementia symptoms. She's not putting the head covers over her head sleeping. But I really couldn't pick between noradrenergic or serotonin, because she's so predominant in those two phases. So in her case, I would probably think I either need to use one of these pathways, a serotonin or a noradrenergic drug, or maybe even both, because she's given me a strong predominance of serotonin noradrenergic dysfunction. So in my mind, if I'm using that model, I would have picked duloxetine or venlafaxine and started her on it at that point and see how we go. That would be using a symptom-based approach. Another method that some people use, psychiatrists use, is you pick a disruptive symptom and you say to the patient, what is the single most disruptive symptom that is keeping you from living your normal life in your relationship? And if they say, if I could just sleep, or if I could just stop being so daggone worried about everything, or whatever that may be, you can then focus your treatment on an agent that has some good effects in treating that target symptom. So like, for example, let's say insomnia is their biggest issue. You could start the SSRI, but maybe give trazodone at nighttime and try to reset or get her into a normal sleep cycle. So you give her a dose of trazodone. If she's still awake in 45 minutes, take another one. You could do it again one more time and try to see her back maybe in a couple weeks after improving her sleep. And then she may come back in. And then you sort of pick the next one and sort of work through it. But that's another mechanism where you're not trying to fix everything. You're just trying to focus on one thing, get some positive response so they're feeling reassured. And hopefully you're all at the same time buying time till that antidepressant sort of kicks in and begins to create some of that circuit improvement that we hope to see. Does that begin to make a little bit of sense? For sexual dysfunction, escitalopram is relatively low. Bupropion has the lowest rates of sexual side effect of any of the antidepressants. Actually, mirtazapine can actually help with sexual side effects in some patients as well. And there are a host of other medications. Like you can do a drug holiday. You can say to the patient, hang in there with me. After about 12 weeks, the sexual side effects should wane if they're going to go away. If they're not going to go away, then they're going to be there. But 12 weeks is kind of the go-to. But if I have someone that's doing well on an SSRI therapeutically, but the sexual side effects are there, I will usually first try a little dose of bupropion, maybe add it once a day, and that will, in many, many cases, resolve the sexual dysfunction. You can change antidepressants, but I'm so hesitant to change antidepressant if someone's otherwise doing well, and we can manage that sexual side effect. Yep, so let's say they're on 100 milligrams of sertraline. Depression and anxiety symptoms are improved, but the sexual side effects are bothersome. I might add a single daily dose of bupropion to them first and see if that won't resolve their sexual side effects or improve it, rather than get rid of that sertraline and try to switch the drug. You could also, if you're using like a longer acting agent like fluoxetine, you could use it where you maybe skip Saturday and Sunday doses, or and dose it just like on the weekdays, and that can often help people have a little bit of a relief. And you can also just do drug holidays where you try to lower the dose for a little bit. So let's say maybe they're doing okay, but you say, well, let's try to put you down to 75 or 50, and let's see how that goes for 3. That's another sort of approach you could use. But bupropion is very special in its ability to help to alleviate some of those symptoms. And so I would much rather add that on as a secondary therapy if they're doing well on their baseline antidepressant. Yes, sir. Personally, yeah, my wife and kids let me know. I have 3 daughters, so they were quick to let me know when I'm irritable. Yeah, they say when I'm typey at work. I get, like if I'm charting late at night on Epic, I'm super irritable. maybe you've been that. You mean with the depressants? Do you mean sort of as a symptom, or do you mean as a start? Yeah, we're going to talk a little bit later today about some of the atypical antipsychotics and some of the other medications that are there for irritability. So hold for that. But I will say that irritability is usually a symptom that you've got some unaddressed noradrenergic activity. And so if it's pervasive, I mean, there's some antidepressants that like will make people irritable. Fluoxetine or Prozac is a real classic one. You see it in older adults all the time. They get just edgy. So I may try a more neutral one like escitalopram or sertraline, and that can resolve. But it can also be a sign that you're pushing the antidepressant a little bit too hard. And so one thing to watch for as you've had someone on their regimen is, are they kind of flat? Their expressive range is not where it should be, or are they experiencing irritability, which is a key feature. And in those cases, I might try to say, you know what? Let's pull back on the dose of your antidepressant a little bit and see how you do. And I think one thing we do is like, okay, somebody's doing really well, but we are very dynamic, complicated people, and the same dose of antidepressant for 10 years might not match life. And so you can regulate that dose a little bit. And irritability is one key sign of that. It can also be a sign of early dementia. So if you're looking at an older population, keep a little eye out and see if there's anything else going along with it. But I usually try to stay away from bupropion or fluoxetine if I'm seeing irritability as a pervasive symptom. But I'm in my sort of symptom battery. I'm looking for, is the expressive range getting narrow, and I'm looking for irritability as a sign maybe I need to back off the dose a little bit. Yes. Uh-huh. Yep. Let me. So the question is about sexual side effects. I mean, I think that just like we focus on all activities of the person's life, if they're in a relationship or have relationships, helping sexual health is an important part of how we restore their, hopefully baseline functioning. And if the antidepressants are contributing, the depression may be contributing to it, right? So we focus on the depression. But if the medications are contributing to it, I do feel very obligated and committed to try to help them overcome that, like I mentioned. But adding sildenafil is a evidence-based strategy to improve sexual dysfunction, like with the SSRIs, for example. It's absolutely a studied mechanism. And these are all of the drugs that have been studied in use in sexual dysfunction. And the ones up top just let you know the alternative path. So give it 12 weeks, because that'll, number one, hopefully before then we know if the depression-related sexual side effects are going away. But if it's the drug and it's persisting after 12 weeks, it probably is, in fact, the drug. And the clinical trials show very low rates of sexual side effects, but they also don't run them long enough to see them. So in real life, they're probably like 1 in 3 patients, actually. You can reduce the dose, which we mentioned, if they're doing otherwise okay, or you could say, like, I had them on a high dose of sertraline. I'm going to pull them down to a medium dose and maybe add another one, or you could do that. You could do the drug holidays, which I mentioned. You could skip the weekend. You could skip a day. You could use fluoxetine in kind of a 5-day-a-week dosing schema. Or if you want to add another agent, these are the drug treatments for the physical side of the sexual side effects. And then using the antidepressant that has a low rate would be like a substitute. So if I was going to switch somebody to a completely different antidepressant from an SSRI who was having sexual side effects, you could try another SSRI if you want. The problem with that is if you have it with one, you often have it with many. So I would probably either use one of 2 drugs. I would either use bupropion or mirtazapine, because they have the absolute lowest rates of sexual side effects. And in fact, bupropion is therapeutically, indicated, not FDA, but the studies support its use as a treatment. So like let's say someone's on 100 milligrams of sertraline, and it took me a while to get there, and they're doing really good, but they're having this effect. And I'm thinking, oh my gosh, are we going to be back at 0 again if this depression rebounds? And I really don't want to adjust their dose. Then I might say, would you be willing to try 2 or 3 weeks of a single daily dose of bupropion added to your antidepressant and let's see if your symptoms. I mean, that is a pretty like low risk, well proven intervention. But any of these treatments have been studied with some outcome data to improve the sexual side effects. And I think there's not enough population studies to sort of say these are the criteria that suggest one over the other. I think you have to try it and monitor the reactions and just stay committed to helping the patient try to get over them. But I'm gonna do anything I can to avoid stopping that antidepressant and changing drugs if they're overall doing well on the antidepressant, for sure. How about we take a little brain break? Y'all want to take a little 5-7 minute stretch break? Y'all were great. Thank you for hanging in there with me. I'm feeling better already. Okay, I'll see you in about 5-7 minutes.